All right. So let me get started. Good morning, everyone. Welcome to Neurology Grand Rounds at the Swedish Neuroscience Institute. My name is Pavle Repovic, and I'm the medical director of the Multiple Sclerosis Clinic at Swedish. It is my pleasure this morning to introduce our speaker, Dr. Tanuja Chitnis. Dr. Chitnis is the inaugural chief of the Division of Neuroimmunology at Mass General Brigham. She's a professor of neurology at Harvard Medical School and holds the Cindy Larson Chag Chair in Neurology at the Brigham and Women's Hospital. Additionally, she serves as the director of CLIMB study, the Comprehensive Longitudinal Investigations of MS at the Brigham. The CLIMB study and biorepository has yielded over 200 publications on MS pathogenesis and prognostic models. Most recently, Dr. Chitnis founded and directs the Translational Neuroimmunology Research Center at the Ann Romney Center, Brigham and Women's Hospital, with the goal of identifying new biomarkers, algorithms, and therapeutic targets for neuroimmunological diseases such as MS, NMO, and MOGAD. Her work has been supported by funding rewards from the Department of Defense, National MS Society, NIH, and other foundations. Dr. Chitnis has authored over 300 peer-reviewed publications on MS and other neuroimmune disorders, and has led several clinical trials in MS, including phase 3 trials in pediatric MS published in the New England Journal of Medicine, which led to the first FDA-approved treatment for pediatric MS. Today, please join me as we welcome Dr. Chitnis for her presentation on advances in blood-based biomarkers for multiple sclerosis. Dr. Chitnis, welcome.
Well, thank you very much, Dr. Repovic. It's an absolute pleasure to be here and to speak to your group. And I really excited to share some of our work that we've been doing. I also wanted to give a special shout out to Evan Medill, who was a former fellow and is now in Seattle, and I'll be sharing some of the work that he has also done on blood-based biomarkers. So I'm just going to go ahead and share my slides, and just give me a thumbs up that you can see my slide. Wonderful. So just to start and give you a quick overview of what I'll be speaking about, it's really focused on multiple sclerosis and our evolving world of blood-based biomarkers. And this includes work on neurofilament light chain. We'll talk about practical uses and considerations in MS. We'll talk a bit about glial fibrillary acidic protein. Also something called the MS Disease Activity Panel and sort of multivariate biomarkers and their potential uses. And then if we have time, I'll touch on biomarkers and other autoimmune neurological diseases and some of that evolving work. So just to level set us, one of the most studied biomarkers now in neurological diseases, and it's been called a troponin for the neurologist, is neurofilament light chain. And this is really predicated on the fact that in MS, we now know, and this is dating back to 1998, this is a seminal paper from Bruce Trapp, demonstrating that there is axonal damage occurring within MS lesions and not just demyelination. And so based on that, we understand that there are neurofilaments, which are parts of axons that can be released into the spinal fluid as well as now into the serum. And we can detect those using now highly sensitive assays. So NFL is one of these neurofilaments, or it stands for light chain. There are also heavy and medium neurofilament chains, but NFL is the one that is the most abundant and highly expressed and sensitive. This is elevated across many neurological diseases, so this is not just limited to MS. Again, it's the troponin for the neurologist, and we know that it's elevated in ALS, in Alzheimer's disease, Parkinson's, and really across the disease spectrum. So what has really spurred the use of blood-based biomarkers is the advent of very sensitive assays to study and test these molecules. And typically in the laboratory, when we're looking for a protein, we do something called an ELISA test, in which you use one antibody that's usually coated onto a plate, put your serum or protein fluid of interest, and then another antibody that makes a sandwich. And that's sort of a very basic concept of how we detect proteins. But there are lots of issues and sensitivity issues to using ELISAs. So some of these more modern assays, something called single molecule array assay, or SIMOA, is able to detect very small levels of any molecule. And this is using a bead that is studied with lots of antibodies now, and this bead detects the antigen or protein, and this bead can now be dropped into a small femtomolar sized well and detected using a fluorescent readout. So that's Simoa assay. And then there's another type of assay called proximity extension assays. And here, two antibodies are used to detect any protein, and then they are amplified using a PCR tag, which can be read out. And then there's also something called the ECLIA or electrochemiluminescent assay, and that is also being used in several centers and is also highly sensitive. So all of these assays have allowed us to measure things like NFL and other factors at very low levels. Now, we know that there are multiple factors that affect blood NFL levels, and this includes by and far the most important is aging, as well as other diseases or other processes that can also cause damage within the peripheral nerves, as well as the central nervous system that can also elevate NFL. So it's not unique to MS alone, and we have to take into account all of these other factors when we are considering NFL levels. So what does NFL use to detect, and what is it really good for? So an important study demonstrated that NFL in the CSF correlated with levels in the serum using the Simoa assay, so this highly sensitive assay. And this was a landmark study that was published by Jens Kuhle and colleagues, demonstrating that, yes, indeed, you can measure it now in the blood just as well or almost as well as in the CSF with a very good correlation. And the main finding with NFL was that it is correlated with the number of new T2 lesions, the number of brain new gadolinium enhancing lesions or spine enhancing lesions as well. So from that study, we learned that this is correlated with new lesions. And now there have been several other studies, including our own, that asked, well, if it's correlated with a new lesion, what is the time frame that NFL is elevated at around the time of a new gadolinium enhancing lesion? And from this very sort of complicated graph here, we see that it's about 90 days around the time of a new gadolinium enhancing lesion that NFL is elevated. And this is using samples from our longitudinal climb study, and we sampled or took samples that were at the time of an MRI with a GAD lesion or just before or just after, and we found that it indeed was this 90-day window around the time of a GAD enhancing lesion that it was elevated. If there was an attack with a GAD enhancing lesion, then yes, NFL was elevated. But if there was an attack without a GAD enhancing lesion, then NFL was not elevated. So pseudo relapses, we did not detect a bump in NFL. So that maybe is also an important clinical point, and it could be helpful for detecting true relapses. So this was an agreement with another study by Varhag and colleagues, again, showing that NFL is elevated for around 90 days around a GAD-enhancing lesion. In their case, it was about 1 month or a few weeks before a lesion and 2 months after. And I think the dynamics of that, why is NFL elevated just before a GAD lesion shows up? And it's partly related to a GAD lesion is really the end result of things happening within that to form that lesion. So the blood-brain barrier is broken down. There are some axons that are damaged, and then eventually you get this very clear GAD lesion. So this is depicted on the schematic where, especially if you are drawing a blood level very early on in this whole process of a GAD lesion forming, then you might not detect an increase in NFL. But if you draw it at the peak around this sort of 1.5, 2 month time point, then you would see that elevation and that difference in a baseline NFL to a NFL associated with a new lesion. And then if you were a little bit too late, then you might miss the NFL bump altogether. So this is why we generally recommend, if you are really going to monitor NFL levels, that it should be done every 2 to 3 months, maybe every month if you're really worried, but ideally every 2 to 3 months. Now, I will say that's not always practical. In our clinic, we see our MS patients every 6 months. So, I do get levels when I can, but it's not always possible to draw a level every month. But maybe if you're worried, then you could ask for that. So this is really the takeaway from this section, and that's really the ideal situation. But again, we have to think about what's practical and also what the reason is for monitoring. Another interesting observation that we had, and several others have had similar observations, is that NFL levels increase more with certain types of lesions. And we actually found that NFL was most obvious, or an increase in NFL when there was a new lesion or attack, was most obvious if it was a spinal cord attack or a brainstem attack. And this is when there was really the most significant difference. Also with brain lesions, and we really did not see a difference when we had optic nerve attacks. So, another takeaway is that lesion location might matter, and that might affect your NFL levels and whether it's increased. So, also the take home from this is if you suspect there is an attack occurring or a new lesion occurring, you should follow your clinical acumen because there may be reasons why NFL is not elevated. It could be timing, it could be location of the lesion, it could be also size of the lesion. So follow your clinical acumen and regardless of the level. Now, what is the use of NFL? I think it's one of those things when it's positive and elevated, it's something that one should pay attention to. If it's negative and not elevated, follow your clinical acumen. So another study that we did was to ask whether NFL was sensitive in detecting new gadolinium-enhancing lesions and what that difference is. And this is a study by Gaurav Bose, who was also a fellow working with me, who asked, if a patient came into the ED and, was waiting for their MRI, and you thought that there was a new attack and a new lesion, what is the sensitivity and what level of NFL change should I be worried about? And from this, we found that the level was about 22 picograms per ml or 23 picograms per ml in our hands. And also, if we looked at what's called a delta change, if we had a baseline NFL level on that patient, in our clinic when they were in a remission or stable state, and then we compared it and did a delta change to that new ER visit NFL, a 30% increase was associated with a new GAD-enhancing lesion. So maybe that's the change to pay attention to and say, yes, I have higher confidence. Now, again, NFL levels are not always positive, so follow your clinical acumen. And we also found that these levels were most sensitive and specific when we were looking at patients under the age of 50 compared to over the age of 50. They're really, it was really all over the place. GFAP was interestingly not associated with new GAD-enhancing lesions. So NFL is really the marker for new acute inflammatory disease activity causing axonal damage. So this is the takeaway from this section. And, NFL, again, is most applicable in patients younger than 50 years of age because, unfortunately, as we all age, NFL is being released. And this is a bit of a confounder in older aged patients, and also comorbidities can affect NFL levels. So when can we use NFL in the whole MS spectrum? There have been certainly studies looking at disease prevention biomarkers. We'll talk about that. It really hasn't panned out as a diagnostic biomarker, and we'll talk about studies related to this, and so it wasn't included in the new McDonald criteria. I think where it has gained the most traction and use is as a treatment response or DMT efficacy monitoring biomarker. And there is some evidence around NFL being associated with disability accrual, more so with relapse-associated worsening and not with PIRA, although it may have some use in both situations. And then also potentially as a long-term prognostic biomarker, it can be used, both for prognosticating and correlating with new relapses. So in this first scenario, so what about prior to diagnosis? This was really a landmark paper from Ketil Bornvik and Alberto Scherio, who found that NFL was increased in people who did not have MS, but they were at risk for MS. And if they had EBV seroconversion, so their antibodies to EBV went up, then subsequently we saw an increase in NFL, really tightly made a very tight and clear association with correlation between EBV seropositivity, the onset of an MS-like process reflected by NFL. And so, could NFL be used as a biomarker to predict MS in people who may be at risk and maybe starting to have the disease process that is subclinical? It's possible, and that is work that's in process now with several other studies showing very similar findings. Could it be used as a biomarker for diagnostic or diagnosing MS? So really, when people looked at early MS and conversion to clinically definite MS, only the very highest percentile of NFL level was associated with conversion. And it could be this time dynamic association of 3 months, and maybe you're not actually capturing NFL. So it really wasn't found to be helpful and contributory to the diagnostic criteria. So maybe not in that situation. But I will say there are patients with RIS that, I suspect they will have dissemination in time, or, are maybe very early at RIS and are not really ready to start a treatment. We do monitor NFL levels to see if those are increasing, and this could be more credence to potentially starting a disease-modifying therapy. So we've also looked at NFL trajectories over time, and here in a cohort from the CLIMB study at the Brigham, which is a longitudinal study of over 2,000 patients followed with both MRIs and blood samples. We found a cohort that had basically annual blood levels for annually for 10 years, and were very early on at their first level from their diagnosis. And here we found that the first year or two of NFL levels predicted their long-term brain atrophy rate. And that was really telling. And it really, the story was told with just the first 1 or 2 years of NFL levels. And this told me that, what happens early on really impacts your long-term outcomes, and probably more credence for high efficacy early treatments. So where it has had the most impact is on disease-modifying therapy monitoring. And here's a nice summary slide from the Swedish and Swiss cohorts, where they looked at a large group of patients and found, also using Z-scores, this was normalized to age and BMI match controls, they found a really clear decrease in NFL levels with the high efficacy oral and monoclonal antibody therapies compared to platform ABC treatments as well as untreated. So, I think this is where if you're starting a patient on treatment, you might draw a level prior to starting therapy, and then ideally see that go down and normalize to normal levels or below. And that is the ideal. So the takeaway from this section is that NFL could be monitored for DMT efficacy and check ideally every 3 months, maybe in the beginning. And then if there is a more than 30% increase, this could indicate a new lesion, and we should certainly investigate further and act on that potentially. So what about progressive MS? So interestingly, in progressive MS studies, and this is from the oratorio studies and also looking at opera patients, NFL was increased when there was a GAD-enhancing lesion in primary progressive MS patients. So that does occur. And I think now we're getting, the understanding is that primary progressive MS is probably more like secondary progressive MS with a very mild relapsing early course. And it certainly can be inflammatory with new GAD-enhancing lesions. So again, NFL increased at those GAD-enhancing time points. And it did also associate with disability progression, but maybe due to PIRA or possibly new GAD-enhancing lesions. So I think the jury's still out on that, but there is use of NFL in PPMS. When we looked at our secondary progressive MS population, we found, interestingly, that NFL levels were associated with cognitive worsening measured by the SDMT, or symbol digit modality test, which is a test of processing speed. And so, another reason to monitor NFL, and certainly if it is high in your secondary progressive MS patients, this could correlate with potentially new lesions forming. We know that some patients have active SPMS, and potentially with processing speed difficulties. Interestingly, GFAP, which we'll talk about, glial fibrillary acidic protein, was not associated with cognitive measures. So I was a bit surprised with that result. So the takeaway from this is that NFL can be associated with cognitive decline in SPMS. It's elevated in primary progressive MS with GAD lesion and can be used to monitor progressive MS. So another paradigm that we've been using NFL in is in treatment discontinuation paradigms. And I think there's certainly been a lot of work and a lot of thought put into should we discontinue treatments in some patients, particularly if they are at risk for infections or other comorbidities or older age? Is there a safe time to potentially discontinue? Or also this could be applied to de-escalation scenarios or extended interval dosing. And here we had a cohort within the CLIMB study of patients who were stable on disease-modifying treatments for 2 years. And then, rightly so, their neurologist said, well, maybe it's safe to stop. And we had a blood sample within this 2-year period and then about 6 months later. And then we asked whether any of these blood sample levels would predict future MS disease activity 2 years later by with either GAD-enhancing lesions or relapses or disability progression. And so what we found was that when we looked at the difference between those two blood levels with NFL and GFAP, that both of them predicted a change or actually a worsening in both of them predicted new MRI activity as well as PIRA or progression. And however, we did not see a difference with attack rates, probably because the attack rates are so few in the future. So there was some predictability of these two biomarkers for future disease activity after discontinuing treatment. So my takeaway from this is that it can be potentially used in discontinuation situations, or, I think there's more data coming out around de-escalation, extended interval dosing, and certainly if someone is changing their therapy and going to a lower efficacy type of therapy, then I would certainly use NFL to monitor that transition and longer term. So some other considerations, we talked about the different assays that are available. And so ideally, just like you'd like to do your MRIs on the same MRI scanner and not jump from 1.5T to 3T and different sequence types, it's ideal to use the same platform if you're measuring biomarkers. And so there are a number of biomarker panels that are available, and this might be different in your area, but in our area, we have access to the Simoa assay through the Mayo Clinic and also the Alexis or ECLIA assay through LabCorp and also something called the Octave proximity extension assay through this company. So there are different turnaround times, and if you're thinking about, which company or how should I be ordering NFL, these are some of the considerations. Certainly, availability, cost, they're all quite good and quite sensitive, but it might come down to what's available in your area. And also the turnaround time could range from a week to less than an hour. So that might be consideration. The cutoffs are different, and ideally these cutoffs should include an age normalized value. So I always look for that age normalized value since we know NFL goes up with age. And these are the reference values from the Mayo Clinic and also from the Roche Alexis. This is an example of a report that you could get. Look at these values. They're very different from the 22 picogram per ml value. This is normal. Interval range is up to 1.87. So just a different range. And this might also speak to how you, not switching between different platforms. So again, some of the considerations for using an individual patient. So the confounders can be age, BMI, renal function, other neurological diseases, and then questions around should you be using a cutoff level? Is my patient above or below a normalized age value? Should I be using Z-scores, which you can convert your values to Z-scores? And should I be looking at a fold change or percent change from baseline? So those are all considerations as we move forward with using these biomarkers in clinic. And then also consider the confounders and differential diagnosis just with any test. So if you had a new T2 lesion on MRI, you would consider the differential diagnosis of that new T2. Could it be microvascular disease, or is this indeed a new MS relapse? And the same thing goes for biomarker levels. So we've talked about this and also the increase with aging. So that's emphasizing that point. And I think also just younger age, what we found in our younger patients is that the levels tend to be higher at the time of a GAD-enhancing lesion. So we've previously shown that pediatric MS patients and younger patients are more inflammatory. They tend to have more relapses and maybe more axonal damage around those relapses. So again, very important to treat these younger patients with high efficacy treatments. That's been our practice. And higher BMI correlates with lower NFL. So just volumetrics is at play here. And so in higher BMI individuals, you might consider a Z-score or controlling for BMI. Correlates with renal function. And also be aware of the reference range or the reference population that you're comparing to. So comparing to a reference population from Europe might be very different than comparing to a reference population in the US. And so I would probably favor a lab that's using local references. So another protein that we'll talk a bit about is glial fibrillary acidic protein. And this is another biomarker that has gained a lot of traction and use in MS. And this is a type 2 intermediate filament that's expressed or produced by astrocytes. And this is upregulated on glial scarring and has been found to be increased in several diseases, including MS. And, I think this was one of the early studies that showed that GFAP is increased in secondary progressive MS patients. We found, and this is a study from Evan Medill using the CLIMB cohort, again, that GFAP is increased in secondary progressive MS patients compared to relapsing remitting. And this makes sense since we know pathologically astrogliosis and badly behaving astrocytes are now at play in secondary progressive MS. Evan also found that GFAP was associated with future PIRA, or progression independent of relapses, sort of weakly, and we didn't find a big difference between the lowest and the highest quartile, but where we did find a big difference was with future gait aids. So the highest quartile of GFAP levels predicted the need for a future gait aid, such as a cane or walker. So GFAP, again, seems to be associated with worsening progressive MS and that biology. A couple of other studies where we looked at the combination of NFL and GFAP in secondary progressive MS, and this is a busy slide, but the take home is that in non-active SPMS, secondary progressive MS, GFAP was high and NFL levels were lower. And that indicated non-active SPMS. But yet when there was disease activity in secondary progressive MS, active SPMS, both NFL and GFAP were high. And this is a sort of summary of that. And so I think it can be used to help stratify where is my patient in this secondary progressive MS continuum. Are they active or non-active? And this might change from year to year. So I think there is value in monitoring both of these biomarkers and considering both of them. Another important study looked at the combination of these two biomarkers from UCSF and found that confirmed disability worsening, which is not quite PIRA, but just was there more disability in general accruing, higher levels of GFAP and NFL together predicted more confirmed disability worsening. So again, value to looking at both of these biomarkers, especially in the progressive population. So GFAP is just coming online, and actually I needed to update my slide on this, but just last week, I think LabCorp is now offering a combined NFL GFAP test, and there has been one available, or it's part of this Octave multivariate test panel, which we'll talk about. So to summarize where we stand with GFAP, increased in secondary progressive MS, reflecting astrogliosis, a sort of modest association with PIRA and confirmed disability worsening, predicts gait aid, especially at its highest quartile. And we have some assays that are still coming online and in development. So another protein that I'll touch on very briefly is chitinase 3-like 1 protein, or it's also known as YKL40. And this is a member of the glycoside hydrolase family, and it's secreted by macrophages, microglia, as well as other stromal cells. And it can be upregulated in a number of after inflammatory stimuli. And there has been some work in using this protein and studying it, and it's been shown to be associated with conversion to MS. It's been increased in the CSF and correlating with disability or EDSS scores, associated with cognitive impairment and also with iron rim lesions. So I think there's a lot of interesting work coming out on this particular biomarker and also associated with disease-modifying treatment response with some of the DMT, so reduced in beta interferon, but not in glutamate acetate treated patients. So I think there is more work to be done on chitinase 3, and it might tell us a bit about the macrophage, microglia, stromal cell axis. Another interesting study found that it was reduced in fingolimod treated patients. And it also was an important predictor of NIDA status in cladribine treated patients. So maybe we're getting at this aspect of microglial macrophage biology and some of these other drugs. So I think more to come on chitinase 3. So now, I've talked about 3 biomarkers. So how do we put this all together? And there are now panels that are being studied to look at the combination of different biomarkers together. And could these be more sensitive in associating with some of these outcomes of interest? And this is the study where we looked at new gadolinium-enhancing lesions, and we looked at a number of different proteins using the O-link assay. And this was in collaboration with a group named Octave. And in this particular graph, we had looked at over 1,000 proteins and found that these 20 came to the top, including NFL, of course, in terms of correlating with new GAD-enhancing lesions. But there were some other interesting proteins, including chemokines and other inflammatory proteins that were also associated with GAD-enhancing lesions. And when we started to put them all together, NFL alone is this black line, and this is an AUC curve. So this is better when the AUC is closer to 1, and we get a better association when we look at the change in NFL levels. And then when we add in additional proteins, we get an even better AUC, and this is now getting closer to the 1 level. So a combination of different multivariate proteins had the highest sensitivity. And so we went through a number of different studies where we looked at over 700 samples in combining the CLIMB and the UCSF cohorts. And we asked whether this 18 protein biomarker panel was more sensitive in detecting new GAD-enhancing lesions, also new annualized relapse rate classification, and also combined clinical relapse scores. And we found that there was a sort of additive value between 2 to 10% of these combination biomarker approaches and in this panel. So this has now been validated in another 1,000 patient cohorts, and this is a clinical test that is available. And interestingly, some of these biomarkers, they point to different parts of both an immune process as well as injury that's occurring within the CNS. And proteins that were included in these panels include MOG and GFAP, reflecting, again, the CNS damage and process that's occurring. Also chemokines that are associated with the inflammatory response and, are indicating probably the peripheral immune cells that are moving into the CNS and causing lesions. So this has been divided into different scores: immunomodulation, neuroinflammatory, myelin biology, and neuroaxonal biomarkers, and there's sort of that that granularity in this panel. So these biomarkers reflect different processes, and I think there's probably more to come on multivariate biomarkers, both for relapsing work as well as for PURA and progression. So there may be more power in adding things together. And this is a typical report that we get from this Octave MS disease activity report. And this is a particular patient who's had a low disease activity score across 2 visits. And these are their biomarker scores and both a absolute value as well as percentile across all MS patients that are being measured is available in the report. So I think it's an interesting now evolution of biomarker reports. I think also very interesting that these other proteins besides NFL are reflecting, again, the CNS process of a relapse, as well as other molecules that have been implicated in relapse biology. So from a pathophysiological standpoint, there's a lot that we're learning about relapses. So can biomarkers predict the long term? And, of course, a question that patients come in at their first clinic visit with is, doc, will this disease really impact my long-term outcomes? Will I need to use a cane in the future? Do I need to think about moving into a different type of home? What does this mean for my long-term prospects? So biomarkers can be helpful, and I think there's some work to be done on this, but this is some early work that we have been doing, looking at baseline NFL and GFAP scores and levels and whether they predict subsequent attacks. And yes, they do. And I think for various reasons that we've talked about. And these values can also predict 10-year MRI outcomes. We've talked about brain parenchymal fraction, but also thalamic atrophy. And interestingly, it's still the first 1 or 2 years that predict these long-term outcomes. And here, this is a score that we put together where we looked at NFL and GFAP levels, as well as over 20 clinical and MRI variables. And these variables included age and sex and typical things, but also T2 lesion volume and brain parenchymal fraction, essentially brain volumetrics. And we found that there was about a 75% AUC for clinical and MRI alone. And when we added 2 NFL and GFAP levels together to this algorithm, or actually independently, we had an 81% AUC. So, you could do it both ways, but biomarkers could help you to potentially predict the future and help advise on disease-modifying treatment planning. So we know that multiple biological processes contribute to disability accrual, and there is a lot of work now reflecting biomarkers or studying biomarkers that reflect all of these different processes. And maybe I didn't quite do that figure justice, but disability accrual in MS patients is not only due to new lesions, but also to meningeal infiltrates, subpeel lesions, diffuse white matter inflammation, these PRLs that we hear a lot about, paramagnetic rim lesions and iron biology, as well as acute axonal damage, and hopefully remyelination is occurring, but that may be not occurring in some of our patients with more severe disability. So it would be great to measure with biomarkers, blood-based biomarkers, a lot of these different processes. And this is where there's a lot of research in the field to look at biomarkers and in correlating with some of these MRI features. And so some of this work has been done by Roberta Magliosi, where she looked at a number of these MRI features. And I'll draw your attention to some of these. Cortical thinning, for instance, was associated with levels of CXCL13, and also BAF and some of the other APRIL, some of the other B cell types of biomarkers. So this is sort of an evolving paradigm. And this was a recent paper in JAMA Neurology, again, finding that certain biomarkers are associated with particularly thalamic volumetrics. And this included TREM2 and this YKL40 that we've just talked about. Slowly expanding lesions were associated with some of these biomarkers. And so we may be getting closer to having biomarker correlates of certain MRI processes. Now, these were all in the CSF. So, I think we'd like to have these in serum, and but the study certainly provided a lot of insights. We looked at biomarkers correlating with 7 Tesla MRI features, including leptomeningeal enhancement and number of foci, as well as cortical lesion numbers. And we found, again, that certain biomarkers, including BAF, were associated with cortical lesion numbers and also lesion volume. So this is evolving work. And So I think switching gears a little bit, so will insurance cover biomarker testing in general? And one of the key hallmarks of whether a test will be approved by insurance is whether we can demonstrate an impact on healthcare delivery and whether it actually changes our management and hopefully improving management, leading to fewer hospitalizations and less use of acute treatments. So here we've done some work in this area, and we looked at whether NFL levels correlated with patient-reported outcomes, and we found indeed that they did with physical role as well as social functioning, interestingly. We also asked whether NFL was associated with healthcare utilization. And this was interesting that we found NFL was associated with intravenous steroid infusion use, as well as a number of inpatient stays. And I think you can start to put those all together if there are more relapses and NFL increases, and this is associated with using more steroids and being admitted to the hospital. And so could this be useful as a monitoring tool to help to at least mitigate and identify patients who are at high risk for these outcomes? So I think in general, in my clinic, I think that NFL is providing a really novel window into the brain. There is several very close associations with new lesions, and it may not be a biomarker of progression, but it contributes to disability accrual. GFAP might be a good biomarker of this, and in combination, they could be used. And I think we're also finding that NFL is useful, but it doesn't necessarily replace MRI, but does provide some additional monitoring and additional information. So just a sort of key to follow your clinical acumen, since it's positive when it's positive, but it may not always be positive in every situation. So I think this is a sort of summary on this section of NFL and GFAP and MS. And we probably won't go through that in detail. So some of the ideal patients that I consider biomarker testing in is patients who are starting or switching treatments, especially those that you're concerned about. Patients with CIS or RIS, this might supplant frequent MRI monitoring, and you might want to know, is this really accruing lesions, and this could be helpful. Patients who are discontinuing or de-escalating therapy, this is a very common scenario that I use biomarker testing in, sorry. And I think those are probably the top ones that I use. So just in the last couple of minutes, I'll touch on biomarkers and other neuroinflammatory diseases, and this is an evolving field. And some of the other diseases that we're studying include NMOSD, and here, just as in other neurological diseases, we are finding that NFL is elevated in NMOSD, and especially around the time of a relapse. But given the biology of aquaporin for NMOSD, we know that that affects the astrocytes. Interestingly, GFAP is also elevated, especially around the time of attacks. And this graph is showing that there is good correlation between serum levels of these two proteins with CSF levels, so also supporting their use as a blood-based biomarker. So this paper has shown, these two papers have shown that both NFL as well as GFAP are elevated in NMOSD, and especially GFAP is more elevated in NMOSD compared to healthy controls and MS patients. So again, speaking to the astroglial biology of NMOSD. And also comparing aquaporin 4 disease to MOGAD and other double negative, seronegative diseases, GFAP is really the one that is elevated. And here, this is a ratio of GFAP to NFL, and this is higher in NMOSD than controls, and compared to MS and MOGAD, so maybe the ratio could be used. And it's another way of looking at it. Interestingly, we have patients who seem to have NMOSD, and we keep testing and testing for aquaporin 4 or MOG antibodies, and they're repeatedly negative. And these patients have low GFAP levels, but compared to aquaporin 4 disease. So this really tells me that double seronegative NMOSD, especially these are measured at the time of the attacks, they don't behave like our typical aquaporin 4 patients. So maybe they do have a different biology. GFAP levels, so unlike MS, GFAP levels in the serum are correlated and increased with attacks in NMOSD. So this could be the NMO biomarker, so similar to what NFL is in MS. And these correlate with attack severity in NMOSD and are particularly elevated with myelitis. So GFAP, again, correlating with attack severity. And these could be used to monitor disease-modifying therapy efficacy, and these do decrease with typical treatments, B-cell therapy, tocilizumab, that are used in NMOSD. So GFAP might be a disease-modifying marker for treatment. So other cytokines that we know are increased in the CSF of patients with NMOSD include IL-6 and IL-8, and I think these, do speak to the biology of this disease and could be used as also biomarkers moving forward. And interestingly, IL-6 levels are increased at a relapse in NMOSD, so that could be an additional biomarker correlating with relapses. I think a little bit harder to measure IL-6 in the serum and blood. It's a bit more of a finicky assay. So this is an overall summary that we put together on all the different biomarkers for NMOSD, and here sort of at diagnosis, aquaporin 4 certainly, and GFAP could be contributory. IL-6 levels could be helpful, and then monitoring moving forward, GFAP levels could be useful for treatment monitoring and also predicting, correlating with relapses and predicting future disability accrual. So in MOGAD, we also see that NFL is increased in MOGAD to some degree, but more so in NMOSD. So, really that seems to be a more destructive, at least axonally destructive disease. And GFAP levels are more elevated in NMOSD compared to MOGAD typically. NFL is elevated in pediatric MOGAD, particularly at the time of an attack. So I think the jury's still out on how to use this in MOGAD, but certainly at the time of attack, I would be very interested in knowing whether my patient is having axonal damage, and this could lead to future disability accrual. I think one of my favorite ways of or uses of NFL measurement, especially in the inpatient site, is in primary, what seems to be either primary psychosis or an autoimmune encephalitis situation. And you have patients who are admitted or come into the ED with this question: is this an autoimmune encephalitis patient? And it's going to take 2 or 3 weeks for the antibodies to come back. And this was a study that looked at serum NFL in that situation and found that indeed it was increased in those with NMDA receptor proven autoimmune encephalitis and not so in primary psychosis. So this is a good distinguisher and very helpful when you're in that acute situation. And this might, help you as the consulting neurologist or neuroimmunologist to decide whether this warrants further workup or steroids or other treatments. So I'll end there, and I just want to share a couple of photos. This is my group at the Brigham, the Translational Neuroimmunology Research Center and Laboratory. And then also this is a picture of the Division of Neuroimmunology at Mass General Brigham. We're a very large group of about 30 neuroimmunologists and 14 fellows. So please do let me know if you're interested in our programs. And I'd also like to thank all of the study staff at the CLIMB study, in particular, Brian Healy, Marianne Polgar, Bonnie Glantz, all of the fellows who work on studies related to the CLIMB cohort, and also to our patients and to our funders. So thank you very much.
Thank you very much, Dr. Chitnis. I'd like to invite everyone who has questions to either type them in chat, or if you are joined using the panelist link, you're also welcome to unmute yourself and raise a hand or speak up. And while you're thinking of some of those questions, I'll just maybe get us started. So you've alluded to NFL standardization and the Z-scores. I'm curious how you utilize them, if you utilize the z-scores when you're interpreting NFL these days, and um, perhaps whether you have any opinion on what the delta on a z-score is, um, maybe actionable, let's say.
Yeah, yeah. So I think the Z-scores are helpful, and it's been very nicely laid out in several of the publications from Jens Coulé's group and the affiliated cohorts. I think the challenge with the Z-score is that you are comparing to a group of Swiss and Swedish, healthy individuals who may have a very different uh, or somewhat different physiology and BMI status than American cohorts. So I do take that into account, and when using or thinking about using Z-scores. I honestly I use the age cutoffs more frequently and just rely on those for typical clinical use, especially since we use the Simoa assay through the Mayo Clinic. But if felt like you wanted to convert these to Z-scores, then I think that's also a reasonable thing to do. Um, and really a 30% change, either in Z-score or in absolute value, is something that I think is actionable and to worry about and to investigate further.
Thank you. We have a question from Dr. Doherty. He's one of our epileptologists. Um, he thanks you for a wonderful talk and is wondering if NFL and other biomarkers could help differentiate between glioma progression versus pseudoprogression. Whether your work, although you didn't speak about it, has that been looked at? Because as we know, NFL can be elevated in other conditions.
Yes, actually, that's a great question. And I haven't been following the glioma biomarker work closely enough to really say whether it has been used in this scenario. I would imagine this is elevated in glioma and also GFAP to some extent too. So I can't comment on whether it is a useful differentiator, but maybe more to look into.
Thank you for taking a stab. Now, just going back a little bit to that GFAP and also linking it to the standardization, I think I heard Jens Kuhle once allude to the fact that Z-scores for GFAP are coming. Are you aware of whether their platform in Basel it,
Yes.
is that here yet, or is it still coming?
Yeah, they are coming, and I think I had a similar conversation at ECTRIM, so I think they are in process of being published or close to publication. So we will see GFAP scores, Z scores, I'm sure very soon being available.
Has in your experience, has NFL change ever alerted you to a different disease process, such as maybe Alzheimer's in an MS patient, like such some just unexpected trajectory that couldn't be explained by MS?
Yeah, so I think there's been two scenarios. One where the NFL level was very high, and it indeed was in a patient with Alzheimer's. So, that was a concomitant pathology that was also happening. And then another scenario where NFL was persistently elevated and sort of over, you know, many months, not just the typical 3 month, but over about a 12-month period. And indeed, we found a pretty severe peripheral neuropathy that's ongoing. So I think, if it's not following this typical pattern, I would be concerned about another pathology and would investigate.
Absolutely. Now, this may not be a fair question, so I apologize in advance, but you alluded to also some of those patients on high efficacy B cell therapies whose GFAP and NFL continue to be high, the highest quartile. What might one do with a patient like that? Someone whose, let's say, Z score continues to be well above 3, um, but you just don't have any sign of inflammatory activity, obviously, in them. What might one do for a patient like that on a B cell therapy?
Yeah, yeah. So I think, I would certainly investigate for other causes of biomarker elevation, and could there be another pathology, potentially AD? We can have elevations of those two biomarkers, so and another neurodegenerative disease. It depends on the patient whether they are clinically stable or they're worsening symptomatically. And so I would, if I had a high suspicion for a process like disease progression, I would also consider high field MRI to look for PRLs or SCLs, maybe other lesion morphology. And we now know that these biomarkers are increased generally with these expanding lesions and chronic active lesions. So that are not really well picked up by conventional MRI. So I would investigate for those processes as well. And if they are symptomatic, is that a process that's occurring, and could this be a patient who's eligible for a clinical trial if they are progressing, especially?
Always a good option to have a trial to offer to a patient like that. Um, we have another question from Dr. Maidev. She is our physical medicine and rehabilitation specialist, working in the Multiple Sclerosis Center, but also with other non-MS patients. She's asking if GFAP is higher in spinal cord atrophy in patients with chronic spinal cord lesions. In other words, does it correlate with, I guess, is it only elevated in a relatively short period of time, or does it remain elevated with ongoing atrophy? If I understand this correctly.
Yeah, that's a great question. I think also I should emphasize that GFAP, we did not find that it changed dramatically over time. So it wasn't quite as dynamic as NFL, which sort of went up, for these 3 months around a new lesion and then went down. GFAP remained elevated in patients, and it sort of signified a change to a more progressive biology. It's a great question whether it's associated with spinal cord atrophy, and that's actually a study that we are hoping to do in the near future, is this correlation as well as prediction of future spinal cord atrophy.
Wonderful. I don't know if there are, oh, there is actually one other question from Dr. Lavasser, one of our MS specialists. Do you see utility in using neurofilament light levels to decide between the use of cladribine as an exit strategy versus treatment discontinuation in patients who have had stable disease for more than 5 years but are younger than 55?
Yes, and I think that is really speaking to some of the conundrums that we run into. Should I stop, and especially B cell therapy in my 50 older patients, and maybe do a de-escalation treatment approach. Cladribine is a good option. Um, and I think, the studies that have been done so far, including ours, have really looked at treatment discontinuation from more of the platform therapy situations. And we still need studies where we're looking at de-escalation from a high efficacy therapy situation to a more moderate efficacy situation. I think the biomarkers could help to guide you. And what I would be looking for was, while on the B cell therapy, they are rock solid stable, so both clinically, MRI wise, and biomarker wise. Then if I, sort of de-escalate, or you're coming off, and I'm just using the example of B cell therapy, so apologies if that's not what you had in mind, that B cells are going to be suppressed for another 6 to 12 months. Again, that period should be stable. And then if I'm considering adding on a therapy like cladribine, I would certainly, use all of the modalities, clinical, MRI, biomarkers, to monitor that transition is going well. And then, once on cladribine, I think the question is, what do you do after 2 to 3 years? Do you redose? Do you add on a different therapy? Could you just discontinue and sort of watch and wait? And that's another situation where all monitoring modalities are important. And I think also biomarkers do have a role there. I hope that answered your question.
I hope so too. But thank you again for giving us this wonderful overview of blood biomarkers, a dynamic field where we'll probably have more updates in the near future. Thank you all for our attendees. I don't believe any other questions have come through to the chat. The CME link should be coming to all of you for today's presentation. And thank you again, Dr. Chitnis. Thank you all.
Thank you. My pleasure.
Have a good day.
You too.